Hey, welcome to another episode of ICU Doc Talk. Today I'm going to be talking about tracheostomies, and It's not necessarily so. So I'm not an ENT surgeon, right? So they're like the experts on tracheostomies, like placing them and managing them and things like that. So I'm not going to be talking about that quite as much. But as a critical care ICU physician and intensivist, I do manage patients with tracheostomies all the time. And I kind of want to share the difference, and obviously, just like in my podcast, this is not an exhaustive conversation. I can't go over everything about tracheostomies, but I'm going to talk about what I think it's necessary for a lot of healthcare workers to know about tracheostomies and how to manage them, particularly under duress, when a patient is in like respiratory distress and they have a trach and what to do about it. Tracheostomies are often very intimidating to people because, right? So for those that don't know, a tracheostomy, what is it? It's a hole in the neck, and then a tube is placed there so someone can breathe, right? That's what a tracheostomy. And a stoma, I'll be using that word a lot. A stoma means mouth, I think, in Latin or something. It means the opening in the neck. That's a stoma. And then tracheostomy is the tube that goes in. It's different than an endotracheal tube, which goes through the mouth or through the nose and then goes down into the trachea. So this bypasses all that. And someone comes along, usually an ENT surgeon, but not necessarily an ENT surgeon, and places a hole in someone's neck. And there's many different reasons. So why don't I talk about the indications, why they're placed, and then what to do about it, particularly in critical illness. So here we go. Okay, so first let's talk about why tracheostomies are placed. So there's many different reasons, and again, this is not an exhaustive list. I will not be exhaustive. I'm just talking about the stuff off the top of my head. So let's just start with like one of the most obvious reasons. So someone needs a tracheostomy if they no longer have a throat. Okay, so that's what a laryngectomy is. When someone has cancer of their throat, like their larynx, usually like squamous cell carcinoma, and it's usually highly associated with a smoking history, and they get cancer. That cancer is going to kill them unless it's taken out. So they get an ENT surgeon. ENT surgeons, by the way, are amazing. I work with them like every day. They're awesome. They're some of my favorite surgeons to work with, and the group I work with is particularly incredible. The attendings and the residents, just a great group of people. Anyway, so ENT will come and relieve them of their cancer, and that's the form of a laryngectomy. Ectomy means to remove something, by the way, as a medical term, if you're not familiar. Ectomy. So laryngectomy. Larynx, ectomy, out. The larynx is out. So literally their larynx is excised from them. It's taken out of them. So that's their voice box. So you can't talk anymore. Well, you can. You just now there's different ways of talking prosthetically, usually by a tracheoesophageal puncture, but that's some discussion for another time. So laryngectomy. So I've covered these all the time. So that is obviously you don't have a hole anymore to breathe through. So a new hole needs to be created. So you'll get a tracheostomy for that, and you breathe through that for the rest of your life after you've had a laryngectomy. Other reasons that an ENT will place one, they'll do it as a precaution. Say they're doing a big operation in the mouth and the throat. They're not necessarily doing a laryngectomy, but there may be a lot of swelling. Like say someone has cancer of their mandible, and that gets resected. Their ENTs do this huge surgery where they take out part of someone's mandible if there's a bunch of cancer there, and then they take their fibula bone, which is in your leg, and they transfer it up. They graft it into as part of your jaw. I know it's crazy. It's a crazy surgery. And then they'll do a tracheostomy as like a precaution. So they may still breathe, up top, but there might be so much swelling and inflammation post-operatively that they'll put in a tracheostomy as a precaution. So usually people like that, they usually will not need their trach long term. So that's another thing. Tracheostomies aren't always needed long term. Sometimes they are, sometimes they're not. It just all depends. So there are surgical reasons to place a tracheostomy. So another reason for tracheostomy is like respiratory failure. So someone in the ICU. So it's very common. And I'm talking about adult populations here, right? I don't do pediatrics. So there's other reasons, tracheomalacia, and there's other, congenital problems that a neonatal or, a child will be born with that they need tracheostomy. I'm not going to really talk about those things because it's not part of my practice at all. I don't do any pediatrics. So adult population. So in the ICU, say someone is, and they have a breathing tube. They've been critically ill for whatever reason. Maybe they've had cardiac surgery, or maybe they're just in septic shock. Whatever the reason is, maybe they're encephalopathic from their end stage liver disease. Whatever the reason is, and they have a breathing tube in place, and you try to take the breathing tube out, and you even do take it out. You feel like their vent settings are pretty minimal, and they're waking up enough, and you're like, okay, great. And then you extubate them. You take the breathing tube out, and you're like, all right, let's see how they go. And then like 6 hours, 8 hours later, 12 hours later, you have to put the breathing tube back in. They go back into respiratory failure. And so someone like that, you're like, they need more time. But, putting a tube in and taking it out is quite a process, because you have to sedate someone, you have to paralyze their body usually to put it in. That sets them back. And having someone awake with a breathing tube in their mouth for a long time can cause skin breakdown of their mouth and of their vocal cords. It can cause vocal cords damage. So it's not a benign thing to have a breathing tube sitting in your mouth and laying across your vocal cords. So that type of patient, you just sometimes you're like, hey, we got to trach him. We got to put him in tracheostomy. And a lot of times for patients' families, it feels like one step. It feels like you're going in the wrong direction. And you not necessarily are. You're just meeting the patient where they're at with their disease state. And it's a tracheostomy is basically like one step back, 2 steps forward. It's because it's very invasive, and you're like, oh, they're so dependent on a vent, and it's like they're already dependent on a vent. They have a breathing tube in. So what this does, putting in a trach in something like this, it helps them to rehabilitate faster. It helps them to, because you can now take them off the vent, and I'll talk about trach weaning. I should talk about that too. I'm probably gonna forget, but I'll see. So what was this? So you put a trach in someone like that to help them to rehabilitate. So once they have a tracheostomy in place, you can now wean their vent, and then try taking them off the vent. And I'll just talk about it right now. So the main process of venting, of weaning something off a ventilator, is you get their FiO2, their fraction of the inspired oxygen, as low as possible. You try to get it down to 50, 40, 30%. And then you don't have them on as much support, that you're, positive pressure ventilation that they need. You try to get that on a minimum. And then you try to, if they have a trach, then you try to liberate them. And we call that a trach collar trial, meaning you take them off the vent and you see how they go just on room air. And sometimes they only go like 10 minutes, and you're like, okay, you put them back on. And then the next day you try for 30 minutes. And then sometimes they'll go for hours, right? They'll go for a couple hours, and you're like, oh, they're doing well. And that's how putting a trach facilitates this process. And then you can even cap the trach. Usually in the United States, we call that a red cap. Why? Because we put a red cap over it. A red cap you cannot breathe through. So a trach has a cuff, just like an endotracheal tube. So if you put a red cap over a trach, you have to drop the cuff, right? Because the cuff is how they breathe. They breathe around the cuff. If you have a cuff and a red cap on, you're suffocating the patient. You have to drop the cuff and put on a cap. You can also do a passe-murray valve, which is like a purple valve, where I work in the United States anyway, which is a one-way valve, where when they breathe in, it opens up, and then when they breathe out, it closes, and it forces the air up, and then they can talk, because you force air up. So you can't talk with a trach unless you have something like this, or unless you have the cuff dropped and you put like a finger over the tracheostomy. Then you force air up through the vocal cords, and then you can talk. Because that's how you talk, right? You have to force air through the vocal cords, and a tracheostomy will stop someone from talking. But if you have a speaking valve on, someone can talk with a trach. So that's kind of the process of weaning someone off of a trach. And then maybe you can switch out for a cuffless trach, and then you just eventually decannulate, take out the trach, and then they're fine. They have a hole in their neck that heals over. So that's how that kind of goes. Okay, so critical illness and respiratory distress, that's another reason for having a tracheostomy. An emergent tracheostomy can be placed when someone is like about to go into cardiac arrest, hypoxic arrest, because they're not breathing well enough. And either an ENT or an anesthesiologist or a critical care or an emergency physician doctor needs to put in an either emergent tracheostomy or an emergent cricothyrotomy. So these are different, right? And a tracheostomy is where someone comes along, and in the trachea, below the cricothyroid membrane, this is all part of the same complex. If you're not familiar with the anatomy, you can look it up. It's not that big of a deal if you don't, for the listening purposes. An emergent tracheostomy is lower. You have a surgical incision with a scalpel, and then a hole is placed in the trachea. An emergent cricothyrotomy is placed percutaneously, and a tracheostomy can be placed percutaneously as well. That means through the skin, percutaneously. So an emergent cricothyrotomy is someone finds the cricothyroid membrane, which is between the thyroid cartilage and the cricoid cartilage. You place a needle. I've done this one time in my career. I hope I don't have to do it again, but I probably will. You take a needle filled with saline, and you pop that in the trachea. while you're aspirating, as soon as you aspirate bubbles, you know you're inside the trachea. You take your syringe off. You thread a wire through that needle into the trachea. You take a knife and you make a slice along that wire to open up the path. And then the tracheostomy, has a dilator within it. And you dilate down, take out the wire, take out the dilator, and now you have a tracheostomy in place. So that's you do that emergently. Now you can do tracheostomies non-emergently, can be placed with like an ENT surgeon under where they do a surgical incision and place a tracheostomy. They can also be placed percutaneously, like I've described with a needle through the skin. And percutaneous placement can be done by pulmonologists. They can be done by surgeons, different types of surgeons, not just ENT. They can be done by intensivists like myself. I've never trained to do them. Intensivists don't do them at my institution, but there's plenty of institutions where a critical care intensivist, either a pulm critical care or an anesthesiologist, has been trained to do percutaneous bedside tracheostomy placements. It's all institutional dependent. If we just happen to do it, then I would learn to do it and I would do it. But we just don't do that at my institution. We either have ENT surgeons or thoracic surgeons or whatever surgeons, or our pulmonologists who will place it. So it very much depends on the institution. So that's kind of reviewing basic reasons tracheostomies are placed. There's other reasons that I haven't touched on to, but I'll just move on. So how do you get someone off? Did I already talk about? Sorry, I'm recording this later. I forgot what I talked about. I don't remember if I talked about how to get someone off a Let's talk about tracheostomy emergency. How to in a critical care setting. Like that's kind of my intent of this whole episode. Let's talk about how to handle a tracheostomy and what to do about it. So when I come into a room, let's say I don't know the patient, and this happens all the time, and they have a tracheostomy and they're in respiratory distress. Okay, what is going through my mind? What do I do? How do I manage this tracheostomy? So I come in the room, and if you've listened to my podcast, you know what I do. I try not to open my mouth unless I need to lead, but I often have residents or fellows that are leading the code or whatever it is, and I allow them and I want them to do that. So I don't say anything. I use my senses to gather information to quickly understand what's going on. If you do that, right, if you use your senses rather than talking when you come into an emergent room, you will orient yourself way faster to the situation. Trust me, it works. Come in, look at the patient, look to see if they're vitals, and then listen to the patient's lungs, put your hands on the patient, and do all this without talking. And you will learn a ton about what's going on. You'll learn the situation quickly. So I come in and look at the patient, and I say, and in my brain, I'm like, oh, they have a trach, okay. And then I sit, and then what are people doing with the trach? Are they like, are they bagging through the trach? Do they have an ambu bag or a Jackson Reese bag, and are they helping assist the patient breathing? Is the patient awake? Are they alert? Are they moving around? Are they not moving? Do they look hypoxic? Meaning, are their lips and skin blue? Do they have vitals? Is their pulse ox super low? Is it high? What's going on, right? And you can get all these things just by looking at the patient in about 2 seconds. You learn this information. So when I come in and I see someone with a trach, there's a couple things I want to know right off the top of my head that I think are very important in managing the trach. And one of them is, how fresh is the stoma? How recently was this trach placed? Also, I want to see if the trach is in or out of the stoma, because remember, the stoma means mouth. That's the opening at the neck. Sometimes it gets coughed out, or it came out, and that's why the patient's in respiratory distress. So that's also another piece of information. If I look and I see a hole in their neck and there's not a trach there, then I'm like, okay, well, maybe they need that, obviously. So I want to know how fresh it is. I want to know if they've had a laryngectomy, right? I talked about that earlier. I need to know that right away. Because oftentimes most hospitals there should be a sign right above the patient's bed or at the head of the bed that says, laryngectomy. This patient doesn't have a larynx, or for whatever reason. Like, it's a warning sign. Because, right, most people have their larynxes. So the reason it's important is when someone's in respiratory distress and you're trying to manage their airway and say they don't have a trach, and maybe their stoma is bleeding, and you can't put a trach back in, or you can't put an endotracheal tube through that stoma. You can also intubate from above, right? Of course you can. And sometimes people forget that. Not forget that, but some people don't think about it because they get so focused on that trach and the stoma and restoring the tracheostomy to that stoma. They're so focused on that like, hey, if we're really in trouble here and this patient's about to code or is coding, just open the mouth and put a breathing tube from above with by laryngoscopy. But you can't do that if someone has a laryngectomy, right? You cannot put a breathing tube from above. It's all sewn shut. It's a blind pouch up there. And if you attempt to do it, you could kill the patient. I've heard about it happening. I haven't been a part of it myself, but I've heard of it happening. So someone trying to put an airway tube from above, putting a laryngoscopy, and the patient dies as a result of this. It's probably because you get into those tissues with your blade, you break up the tissues, and you probably get into some vessels and bleeding, and then you cause bleeding that probably gets down into the lungs, cause hypoxia. There's probably many ways someone can die from this, but that's extremely dangerous, right? Nobody should ever, ever, ever be doing that. So you need to know if someone has had a laryngectomy, right? And then if they've had a laryngectomy, and when a code is called, or a rapid response, we call it in the United States, which is not quite a code. So also code blue in the United States means like cardiac arrest or respiratory arrest. Someone does not have a pulse. That's what we call it in the United States, code blue. I know that's not what it is elsewhere, but it's a cardiac arrest. It's called the code blue. A rapid response is where you get a team in there to try to reverse a patient that is deteriorating. They're not pulseless, but they're deteriorating. That's usually typically across the United States. It's not just my institution. It's usually called a rapid response. Anyway, so what was my point? So I forgot what I was talking about. I lost my train of thought. Okay, I got it. I had to go back and listen. When a code blue is called, there's a lot of people that come in the room that do not know the patient, right? So I've come into a room and so they don't know it, and they start doing their thing, right? Which is fine. That's what they're trained to do. But I've seen, someone trying to a patient with a laryngectomy trying to be bagged from their mouth, right? Like trying to pump air through the lungs from their mouth, and they have a laryngectomy. So that's not harming the patient. Well, maybe it's harming the patient. It's not helping the patient so you need to bring that to the stoma, right? That's the only way they're breathing if they have a laryngectomy. It's the only way they're breathing is through that stoma at their neck. So you got to bring that. If they've had a laryngectomy, do not try to do anything in their mouth. Yeah. So anyway, so I want to know how fresh is the stoma. I obviously want to know if they've had a laryngectomy. And then inspecting it, what is the origin? What is the etiology of this respiratory distress? Are they bleeding? Is that stoma bleeding? That's a big deal. So if I look at that stoma and there's blood around it, and they no longer have a trach in it, now you're having problems. And the next thing that's usually out of my mouth is, we need a fiber optic camera in this room right now. It's usually the next thing out of my mouth. And we also need ENT in this room, right? Because typically it's an ENT patient, but not always. And so ENT, I want ENT, usually a resident, because I work at an academic center, I want ENT in the room as well. To come and help manage those. So they're probably on their way. Oftentimes they're already on their way, or they're already in the room when I'm there. So yeah, is there bleeding? Where's the trach? How fresh is the stoma? And have they had a laryngectomy? Those are the things immediately that I want to know right away when I'm managing a patient with a trach and respiratory distress. Now, one of the things in this situation, let's say someone is having bleeding around their trach and they're hypoxic and they're not doing well. One of the things that's tempting to do, but it can be very, very dangerous, is, and say their trach, they coughed it out, they don't have a trach, and you're trying to get control of it. One of the things that's very dangerous to do is to blindly shove that trach back in. So for one thing, if someone's hypoxic and hypercarbic, like they're not ventilating well and they're hypoxic, they're also extremely agitated. So one of the lesser known side effects of hypercarbia, which is, too much carbon dioxide when you're not ventilating, yes, it's a narcotic, meaning not necessarily like a narcotic like in the traditional sense, but it causes narcosis. Hypercarbia causes narcosis, right? It sedates people. But it also, once it gets really severe, it can cause severe agitation. Like, people can be absolutely wild when they're hypercarbic, have extreme hypercarbia. I see it all the time. And it gets forgotten often. People are like, well, it can't be hypercarbia because they're not sedated. Like, no. They can be, agitation is a huge sign of hypercarbia. So my point is, someone who, they cough out their trach and they have bleeding around their trach, they can be thrashing in the bed. And to take that trach and to shove it back in to a bloody stoma that's immature, that's new, is dangerous. Because you can put it into a false lumen, meaning you can shove it into some tissue and not into the actual trachea. And then you start bagging, and you're bagging tissue. You're ventilating tissue. You're causing a bunch of crepitus, probably swelling around that trachea, and you're also not ventilating them. And now they're on their way to dying rapidly. So one of the things that is very dangerous, it's tempting to do in this situation, is to blindly shove a trach back in. Do not do that. That is not a good idea to do. So that's why you need a fiber optic. a camera. So in this situation, there's a couple things I could do in this situation. Let's say it's bleeding and they're having trouble, and you got to put it back in. Now, of course, again, you can also just like sedate them and intubate them from above, assuming they haven't had a laryngectomy. That is always an option. You can always do that. That's usually something you can do. Another thing you can do it. So if you can take a fiber optic camera and load your tracheostomy over that, okay, load it over it, and then put your fiber optic camera down the stoma. Make sure you see the carina, which is or tracheal rings, and then you slide your tracheostomy off of that fiber optic camera and into the stoma, and now you know you're in the true lumen, the trachea, and then you're good to go, and then you can start ventilating through that. Sometimes you need to give a little ketamine. You can give them some sedation, like some boluses of ketamine is fine. It doesn't cause respiratory depression. Romimazlam would probably be a good example to settle them down. Now, if things are really going wrong and you have a fiber optic, you can't really do this. If they're about to code and they're so hypoxic. So if you really, really need to do this, if I need to do something very in a quick pinch, you just take like a 6.0 endotracheal tube and just pop it in. Now, yeah, you also might be into a false lumen, but it's a little more flexible. It's not as rigid as like a Shiley endotracheal tube. Or a styleted Bavona tracheostomy. Those are different types of tracheostomies in the United States. Shiley is more rigid. A Bavona is more flexible, but it has to have an obturator. Anyway, you don't need to worry about that. You can just take a 6.0 endotracheal tube and pop it in and see if you can ventilate through that. If you really are in a pinch, or just intubate from above if you can. Now, if you pop it in an endotracheal tube, it's easier to place, right? It's flexible. It's way easier to put in than a trachea, particularly if they're also like thrashing in the bed. You can just pop in the tip. Do not advance it too far. It's so easy to main stem intubate when you do it this way, because right, a stoma is lower in the neck. So if you put an endotracheal tube, which is a long thing, it's supposed to be go through the mouth. That's long, and if you advance it, it's so easy to advance that too far. But trust me, it's extremely easy to do that. So when I put it in, I just pop it in barely in there. I inflate the cuff, and I can see the balloon inflate, and I leave it there. And then you must listen for bilateral breath sounds. Make sure you haven't main stemmed. Main stem is where you put the endotracheal tube too far down one of the lungs, right? Like down to usually the right side. You put it down too far, and then you're not ventilating the other lung. So it's very easy to do that if you try this technique. Okay, so I'll share a story about managing. So I had a patient. It was a rapid response. I didn't know this patient. I came into the room, and and it was a patient who clearly, using my eyeballs, I looked at the patient. They were clearly in respiratory distress, and they had a stoma, and the tracheostomy had been coughed out or something. Okay, and they were clearly in respiratory distress. Their pulse ox was okay. They were probably satting in the high 80s, and they had significant work of breathing. The patient was awake. They were not about to code or anything like that, but this clearly it's kind of an emergent situation. We must control this airway and help to ventilate her and, and rescue her from the situation. So I noticed that they were bagging the people in the room. They were providing oxygen through the patient's mouth. And I asked, I listened to the patient's lungs, and they had bilateral breath sounds, and they were breathing spontaneously as well. And I was like, has this patient had a laryngectomy? And no one really knew. I didn't really get any answers. And then finally, after a minute, someone's like, yes, they've had a laryngectomy. And I was like, okay, we need to bring the oxygen delivery down to the stoma at the neck. So we did that. And then I looked at the stoma, right? And it was clearly fresh. Just to my eye, it had been created fresh, like recently, right? It wasn't a mature stoma. It didn't have a bunch of nice healed tissue around the stoma. It was raw and fresh looking, and it was also a little bloody. It wasn't acute hemorrhaging, but there was clearly like bleeding going around. So this was the situation I was describing, and I was like, I'm not going to just take this endotracheal tube and shove it back in, because I'm going to make matters much worse. And so I was like, we need a fiber optic in this room. And the patient was and obviously I can't intubate from above. And I was like, yes, I can always put in a 6.0 endotracheal tube if I need to in a pinch. But I was like, he's kind of okay. Let's wait for the fiber optic. And it was far away, right? This was not during the ICU. So I was like, you know what? So I had this choice, right? I could either try to blindly kind of fix his airway and potentially cause worse damage by putting into a false lumen and actually making things way worse for him and causing bleeding and then making the situation way worse. So rather than do that, we elected that less is more. We're like, okay, let's wrap him up as he is. He's breathing spontaneous. We're delivering a little oxygen. around the stoma, and let's take him to the ICU where we can then properly address his airway. He's stable in this condition. He's not doing well, but he's stable. So everybody agreed that that was an okay plan. And then unfortunately, as we were kind of gathering him together and getting him to go, an ENT resident came, and she had a handheld fiber optic camera. And so she now with this new equipment and the situation changed, she then secured the patient's airway with a tracheostomy with a fiber optic camera. The patient was fine, went to the ICU anyway. So in this situation, I'm just sharing the story because less was more here, and waiting for the proper equipment to not make things worse. Very, very important. Lastly, there's a lot of stuff to talk about, but the last thing I want to talk about is how much pressure we put into a trach. Okay, so a tracheostomy has a balloon, right? That's how you create a seal. So a tracheostomy is just a tube. I should have explained this at the beginning. If you don't know what a tracheostomy, it's just a tube. Just imagine a tube that's curved, and it has a balloon on the outside of it that inflates, while still maintaining the patency or the opening of that tube. And that balloon, you inflate it, and it creates a seal around the trachea, around the tracheostomy tube, so that air doesn't leak past it, so you can ventilate somebody. So it creates a seal. It is extremely important to not put too much pressure into that balloon. And it's a very easy thing to do, to put too much pressure into that balloon. So the trachea has a blood supply, right? It's supplied by the arteries. There's blood supply to those tissues to make sure that those tissues are nice and healthy and they have good blood supply. If you have pressure greater than 25 centimeters of water, you now start and you apply that pressure in a balloon, like in an endotracheal tube or a tracheostomy tube. You are now cutting off blood supply to that portion of the trachea around 25 centimeters of water. You now block off blood supply. It stops being well perfused. Around 25 centimeters of water, which is not a lot of pressure. So it's very, very easy. If you come along and just put say it's just like an endotracheal tube, and you just put 10 cc's in it, you will very likely have overinflated that balloon. Very likely, with just 10 cc's. Particularly if it's like a small person or it's a woman who tend to be smaller. You probably have put like 50, 60, easily 70 centimeters of water in that balloon just by blindly putting 10 cc's in, which is very common. This happens all the time. Now, so context matters. So if someone puts 10 cc's in a balloon during like an anesthetic procedure, right, 2-hour procedure, and so for 2 hours they have like 60 centimeters of water, and the blood supply to the trachea is a little compromised, is that going to make a difference? Very likely not. It will not. Nope, probably won't. They're going to be fine. They might have too much of a sore throat. If you had put less in, that patient might not have a sore throat. So I'm not saying it's benign, but you do that over an hour, 2 hours, maybe even 5 hours with a little bit too much pressure. It's probably not going to cause any problems. I don't think, at least. I could be wrong about that, but I don't think it's going to cause any long-term problems for that patient. Well, let's compare this with a tracheostomy in the ICU. Okay, let's say that person has a tracheostomy and someone puts in too much air into that balloon, and now they have 50, 60, 70. Remember, 25 is where it should be at. And it has 50, 60, 70, 80, 90 centimeters of water. That's way too much pressure in that balloon. Now, you can measure pressure, right? There's manometers, pilot balloon manometers you can stick on there, and you can measure how much pressure is in these balloons. These exist. This device exists. You can precisely measure how much, and I think it's standard of care. I think we should. But anyway, let's say someone has tracheostomy, and they have 70 centimeters of water in that tracheostomy in the ICU, and they sit like that for a week and then 2 weeks with that much pressure in their balloon. And that portion of their trachea is being underperfused. Now you may be creating a life-threatening problem. Why? So you're weak. So if that portion of the trachea is doesn't have good blood supply, it's now getting weak, right? It's scarring, it's damage, it's getting weaker. Well, the innominate artery, which is a major artery that comes off of the aorta, right? High pressure artery runs right by the trachea. So what can happen is as the trachea tissue starts to become degraded and weakened, it can start to form a tunnel to that aorta, to that artery, and then you get what we call a tracheoinnominate fistula, and that is as bad as it sounds. It then opens up, and then you now have high pressurized arterial blood flow coming into the trachea, which is not very survivable, right? People most usually die. If this happens, it needs to be, you recognize it, someone needs to put their finger in that hole and then emergently go down to the operating room for a cardiac surgeon to open their chest and then correct that defect. which is very unlikely. So here's my point. A lot of pressure over you multiply that over days and days and weeks, you have breakdown of those tissues, and then you get a tracheostomy fistula, and the patient can die. That's the danger. So a dutiful RT, respiratory therapist, should be checking trach pressures every day, right, in the ICU to make sure that those pressures are not too high, that you're not forming a tracheostomy fistula, a catastrophic event. This is a catastrophic event where someone can die. Okay, anyway, that's all I'm going to share about tracheostomies. So there's a lot to say. Email me with more questions about that at icudoctorecmo@gmail.com. I think I have a good question that I got from an email. Let me check it out, and I'll talk about it. All right, this email is from Jack, last name withheld. Jack says, "Hey, Doc, love your podcast. One thing I was wondering, listening to you, is what you did during your undergraduate education before you got into medical school. Right now, I am a pre-med student, and I have been listening to you talk about what you do, but I'm feeling kind of lost as a pre-med student, and we're wondering if you had any thoughts about how to focus your attention and time." So, Jack, it's an awesome question. Really great. So I'll just try to answer this briefly. So the first part of the question is, I was wondering what you did during your undergraduate education before you got into medical school. So in my undergrad, I studied chemistry, and that's what I majored in. I always wanted to be a writer. I've talked about this before in med school, but I realized that was not like a, very, feasible thing to go into. And, just like Jack, I who wrote the email, I can understand being, feeling like, like kind of aimless, like, I guess I'll be pre-med, I don't know. And I think it's that kind of uncertainty with what you want to do with your future, what you want to go into, is sometimes you just need to sit with that. And there's not much you can do about those feelings of uncertainty. My first bit of advice is, if you are blessed and fortunate to be in college and be in that opportunity to begin with, and get a degree in something and be educated, whether you go to medical school or you go do something else, your career. Unfortunately, we live in a society where a career defines what we do, and I don't think it should. So I think lower the stakes. The stakes, that's easy for me to say, I guess. The stakes are sometimes quite high, right, in terms of like earning potential and things like that, if someone has a bunch of student loans or whatever. But I don't know. I think lowering the stakes and going easy on yourself, and that every young person in their 20s has this vision of what their life's going to become. It will be different than what you envision. You'll probably go down different paths. And I think just embracing that uncertainty, that chaos, is really important, I think, for your current mental health. For me, anyway, in undergrad, I considered going into chemistry, but getting a PhD in chemistry and going that route. But I really didn't want to do bench work and science. Like, I wanted to be with people, and so medicine was a nice marriage of these two things, right? But I had plenty of discouraging moments. So I tried to get into med school. The first time I tried to get in, I did not get in, right? I applied to a bunch of schools, and I took the MCAT. I got a very, very average score on that. I had good grades. I was obsessed with my grades and always, trying to get good grades. So I did have good grades. But my first year trying to get into med school, I did not get in. I got one interview, and I did not get into that school. And it was very discouraging, getting that rejection letter from that one school. I was like, it's terrible. It's terrible. But, I got over that pretty quick. And I was like, I'll give it one more shot. I'll try one more year. And that last year of my, undergrad was one of the hardest academic years of my entire life. Because I retook the MCAT. I got a better score. My parents helped pay for a course to help me get a better score on the MCAT. Right. So I had those resources, parents that were very encouraging and very supportive, and they supported me financially. Not that I didn't grow up, I grew up very middle class. But my parents, had at least enough disposable income to help me with my education. But anyway, so I tried, and I was like, hey, if I don't get in, that's fine. I'll do chemistry. And I got lucky. Luck has a lot to do with it, and got into med school. But I don't know, for Jack and other people in your current circumstances, I would say just, I don't know. I'm with you. I've been through it before. It's difficult. Don't be so hard on yourself. accept that the future that you envision for yourself will very, very likely be different as it results. And I think the most important thing is doing what makes you happy, that you feel like you are yourself and you're not being someone that you don't want to be. I don't know, maybe that sounds a little contrived, but that's kind of how I feel. And if you're not feeling it, if it's not something you want to go into, just don't do it. Go into something else. Go into something else. I mean, I have enjoyed my career in medicine, but not everybody does, right? I think it's been great for me, but not everybody does. And it's a long road ahead of you if you do go into medical school. Very, very long road. So anyway, I hope that helps Jack and others like him. All right, let's go on. Let's talk about a book. I read a lot of economic books. And I have never formally studied economics, and I don't claim to be like super knowledgeable about economics. Although maybe I sometimes do because I make TikTok videos about economics and that ruffle some feathers. But whatever. I read lots of economic books, and the reason is it's not like finance. Like I don't care about finances. I'm not like it's not to understand how to make money. That's not my interest in economics. My interest in economics is I'm interested in learning how power works. And I'm fascinated by power, how it works, political power, economic power. So I'm obsessed with reading about economics. So I'm going to talk about an economics book. It's one of the best economics books I've ever read. And it's called The Value of Everything by Mariana Mazzucato, Mazzucato. It was published in 2018. It's about 380 pages. So I've read at least over 50 economics books. And The Value of Everything, the name of the book, The Value of Everything, Who Makes and Who Takes from the Real Economy. The author takes you, first it's kind of a history of economics, of how value was defined and how it has become deranged today into this enormous financialized rent-seeking behemoth that siphons off wealth. The book is a balanced book. It's mostly apolitical. It's written by a PhD in economics. And it's not a polemic. It's a well-thought, well-researched critique about the current economic system. The author gives us a nice overlay of the transformation of the word value, what it meant, what it means, and how its definition has changed over time with huge impact. The TLDR, right, too long, don't read version of what I'm about to tell you, is that value has been redefined from things that produce into things that don't produce, as long as they are private entities, right? So that value has been redefined, and I'll get into it. So what this means is broad financialization that has occurred since the 1980s has suddenly been deemed to add value, except that it only increases shareholder value. And then there's this other prevailing wisdom that anything that the government does not produce value, even though the government provides tremendous value to its citizens, unequivocally. It's this broad redefining of value that has created an enormous rent-seeking apparatus that results in mass wage stagnation and wealth concentration. So the author starts at the beginning of this book with classical economics, and she does a really good job with an overview of Adam Smith and Ricardo and Karl Marx and their contributions to what is considered to be valuable or not. Adam Smith helped develop a lot of labor value theory. He believed growth depended on increasing the share of manufacturing and wage laborers, and free trade was essential to bring this about. Enemies of growth, according to Adam Smith, were the protectionist policies of mercantilism, as well as guilds protecting artisan privilege and the nobility who squandered its money on consumption and unproductive labor, right? That's Adam Smith. He believed that hoarding cash prevents nations from spreading wealth. Smith's theories were basically against mercantilism and for more free trade, right? Mercantilism was like guild mentality. And so he was all about free trade without tariffs and without rent seeking. Smith's free trade principles traced value to labor and not to gold. Ricardo was all about how the distribution of wealth was created from labor, and he was opposed to rent-seeking constructions. And then Karl Marx understood that labor power is what allowed surplus to even happen to begin with, which is then exploited by capitalists. Karl Marx understood the ingenuity of capitalists who organized workers to create surplus value, and Karl Marx foresaw the deleterious effects of mechanization and financialization and how it undermines workers. That's what I enjoy about Marx's text. Not that I think Marxism is like a viable economic model. I don't think it is. But his critiques about capitalism are very spot on. Anyway, she talks about how there's basically four types of capitalists. There's the production-bearing capitalists, commercial-bearing, interest-bearing, and then landowners. So anyway, so after the classical economic movement, you have neoclassical economists who overturned the labor value theory. A new theory was developed that dictated that a price is set by the value the buyer gives it and not derived from the labor that created it. This is key. This is the main point. You flash forward today, and this is the exact same rationale greedy drug makers will make when they're talking about why their medication costs tens of thousands of dollars. They argue the price is high because of the value it brings. The value is the price, even though the cost and labor to produce are way smaller than the price. This is called marginal utility theory, and it's part of neoclassical economics. Marginal value theory creates hyper-individualistic economic theory and hypercharges the consumer. It was this shift from classical thinking that saw rent sinking as parasitic into neoclassical view that saw rent sinking as something that added value to the economy. Now in the modern economy, we count financial products and rent sinking as part of the GDP and consider it to be of productive value. The difference between profits and rent is obscured, and it's all taken as being productive. Finance made a huge shift in the 1980s into being like a value-adding entity, but all it did was extract wealth and inflict wage stagnation. From leverage buyout to stock buybacks and junk bonds, and shadow banking and transaction costs, the majority of Wall Street is an enormous rent-seeking apparatus. It's been the transition from stakeholder to shareholder value that has created this paradigm shift, right? Stakeholder value is considering all the stakeholders in a company, including the community and the people that work for it, and it's shifted to shareholder. Like all you care about is the shareholders. There are only short-term profits now, right? That's all anybody cares about, that's in charge. After the author explains all this in great detail, she then goes on to expound on all the ways the government adds value, either by Keynesian economic policies or just straight up direct investment and production of key technologies. The government helped fund or directly, the U.S. government helped fund or directly created many technologies we use today and that private companies exploit, like semiconductors, touchscreen technology, the internet, GPS, nuclear technology, fracking, battery energy, and a lot more. 2/3 of pharmaceuticals were developed and funded by the NIH, a government institution. So let's be clear. The government directly and indirectly creates value. Now, when I say something like this, right, that the government creates value, some people think I'm picking an ideological fight, and they smell blood in the water, and they go off on what the government's role is supposed to be, and they start talking about ideology and theory. But I'm just stating facts. The government has and does literally create value. It's not an ideological turf war. It's literally a fact. So basically, why do people give a pass to corporate failures, but they don't give a pass to government failures? The government invested in both the failed Solyndra company and also the successful Tesla company. But you don't hear about how successful the government was in the EV revolution with Tesla. All you hear about is the failure of Solyndra, which was a disaster. I'm not saying it wasn't. The government fails and succeeds just like any other investor. The success of venture capitalism has to do with nothing more or less than happenstance and timing. National accounting, right? People who figure out GDP and stuff like that, they don't account for value, government value, employment, and the profits that the government is responsible for. So it makes the government appear unproductive. And tons of private companies then capture and claim that value when all they're doing is rent sinking and concentrating wealth to shareholders. Right? That's the essence of this book. It's amazing. You should read it. It's called The Value of Everything by Mariana Mazzucato. All right, that's all I got for today. Thanks for listening. You can send me your thoughts to icudoctorecmo@gmail.com. icudoctorecmo, ECMO, @gmail.com. I'm on TikTok. ICU Doctor is my handle. I'm on Instagram, ICU Doctor TikTok. If you enjoy this podcast, please leave a review because it helps to spread it, and then share it with people and talk about it if you would like it to grow. My goal will always be to never have any advertising and to never get paid for this, which I currently don't, and I don't never plan on that. It's a public service that I enjoy doing. So if you also like it and you want to support it, just talk about it. Thanks for listening, and hopefully have another episode soon. Thanks.